Welcome to the Principles of Performance podcast, where we discuss how to optimize your health, fitness, and performance. Drawing on decades of experience of working as coaches, consultants, and trainers to top performers, athletes, and teams from professional sports to top universities to the U.S. military, Eric DeGatti and Mike Perry discuss topics and strategies of how to perform at your highest level and be your very best. Join us and our friends and colleagues who are leaders in the fitness and performance industry as we investigate and challenge the most popular training, nutrition, lifestyle, and recovery protocols. And away we go. Here we are at episode number 32 of the Principles of Performance podcast. This is going to be an awesome one. My name is Eric DeGatti, your host, along with my co-host, Mr. Michael Perry. Mike, you ready for today?
I am. I've never been more ready for anything in my entire life. So let's get ready to do this. We've got two amazing gentlemen on the podcast today, and I'm looking forward to learning.
Yeah, you and I both be ready to learn and be inspired. So here's who we have today. We have Steve Cairns and Crispin Barker. They work together on something called the Movement Project, and where they volunteer their time to provide weekly movement training sessions for people around the world to help them with regain their movement skills after brain injuries. And we'll talk a little bit about how I've had the good fortune of getting involved in some of those sessions recently. So let's tell you a little bit about Crispin to start with. Crispin Barker is a physiotherapist who graduated from Brunel University and worked at UCL hospitals in London until 2007. He and his wife then moved to Bristol and started work in pain management service and chronic fatigue services by using biopsychosocial, easy for me to say, Mike, and cognitive behavioral approach. He continues to work with the service comprising of occupational therapists, psychologists, and physiotherapists. He's also studied and taught Tai Chi for over 30 years, as well as being a level 3 AIDA free diver. Okay, so kind of cool right there. Okay, but here comes one of my superheroes in life, and I'm not kidding with this. You ready for this? All right. Steve Cairns has several accomplishments to his credit. So here's the first one. He's an ultramarathoner. All right. He's completed races, including a 100-mile West Highland way race, a 50-mile Caballo. I don't know if I'm saying that right. Caballo Blanco Ultra. That's the race that's featured in the best-selling book, Born to Run. And the 50-mile Taft Trail. He did all those twice. As well, he's done the 80-mile Ridgeway Challenge and the Marathon Disable, which is 150-mile across the Sahara Desert, carrying all equipment in a kit. All right. So, all right, you're thinking, okay, that's pretty cool in and of itself. All right, so let's keep going. Steve also spent 14 years in the British military with 2 years airborne and 12 years special forces. That's 23 SAS. Okay, it's almost like our Navy SEAL, so to speak. All right, so you're thinking, all right, we got like the British David Goggins on our hands, right? Well, here we go. Here's the craziest part. In 2017, he suffered a catastrophic stroke as a result of a brain hemorrhage and required 10 and a half hours of surgery on his brainstem, which is the most fragile and eloquent part of the brain. Lost all movement skills, and prognosis was a 2 to 3 year recovery with permanent deficits and possible need for a walker or cane. Disagreed with the doctors and signed himself out of the hospital in a wheelchair. All right. Rehabbed himself and smashed all his prognosis targets inside 10 weeks. All right. He's a member of the External Advisory Medical Board for Hypertrophic Olivary Degeneration Association, HODA. Did I say that right, Steve?
Yeah.
And HOD is a degenerative ataxic condition that can present itself with individuals who are post-brain injuries. So that's a lot to soak in. And I want to tell the story how kind of I met Steve, but let's start off by, Steve, you kind of tell everybody your kind of remarkable story and give us a quick recap of kind of how you found the courage to and the resolve to do what you've done.
You just covered it all, haven't you? I'm not sure that courage and, well, maybe resolve might be fair, but I think it's a little bit different when you're in the situation than I think than those around you. Because I mean, poor me just does not go anywhere. I mean, while she might be deserving of sympathy, it's just not going to help. And so, you know, the only person who's going to make a difference here is yourself. Or rather, if anyone else is going to make a difference with you, you've got to be up and owning it. With respect to disagreeing with the doctors and that, I suppose it goes back to some of the stuff you covered there prior to. When I was with the regiment, the last 6 years, which was sort of 3 years either side of a tour of Afghanistan, I was on the regimental training team, and our main task there was preparing and managing recruits who were going up for the selection course, which was spread over 6 months, and finished with something it's called Test Week, a pretty grueling assessment. I think there's Hell Week is something which the SEALs have, so it's a different beast than the SEALs stuff. It's a lot of it's solo navigational walks, carrying huge amounts of kit over the mountains. But anyway, for that first 3-year period, well, 5 out of the 6 courses yielded only 1 successful recruit. The average pass rate was between 0 and 1%, and the reason why guys would fail who we felt had the necessary mental and physical attributes that we'd associate with success was through injury, and not sort of falling over and tearing a cruciate. It was sort of chronic sports injury, iliotibial band syndrome, lower back problems, ankle and knee problems. And so when I was away in Afghan, I knew when I'd come back I was going to be a senior figure on the team. So I wanted to take that on and find out why it was happening, because I'm not having it that, you know, guys just aren't as tough as they used to be, because these fellas were, you know, the fitness levels when they turn up are through the roof. And we wanted to find out what was going on. So the first thing we did was look at their, I was introduced to Gray's work then. We didn't actually use the FMS. This would have been 2008. We didn't use the FMS. We were aware of it, and we sort of took on the principles, if you will. And what we tried to do is gear our training around producing bodies which would score well on an FMS. We realized straight away that these guys live in the Western world, so they turn up with the postural and mobility flaws that, you know, you'd associate with the seated lifestyle. And so we corrected that. That didn't make too much of a difference. And then we stumbled on, but didn't stumble on, we rationalized that just because they could move correctly now doesn't mean that they will. And so we focused on movement quality, which got them rolling. Well, tried to reset their movement, and so take it right back to the neural development sequence with rolling, crawling, kneeling and squatting. And then, hey presto, the results went through the roof. We had over 50% pass rate with exactly the same test. The last course we did, our location had the fewest recruits at the start than all of the locations. But at the end, we had more passes than the rest of them put together. And because of the sort of success we used to have with that, I swear this is true. I honestly used to wonder, why don't they use this with brain injury patients? And then, obviously must have wondered a little bit too hard and got given the chance to walk me talk. Although in between that, 2014, that was when I first met yourself, Eric, in Raleigh at the Perform Better Summit. And, that just further, got me FMS, credentials in. And I just went more and more down the movement quality and got invested in the neural development sequence. I used to use a neural development sequence warm up for every single session I'd do prior to going into the hospital. And so I had a brain hemorrhage from a non-cancerous vascular tumor called a cavernoma on my brainstem, and yeah, that was it. Then I was pretty smashed with that. Vision problems, obviously unable to walk. I had the worst hangover I'd ever had, and I hadn't earned it. And well, I was scheduled for surgery to remove the tumor in 2 weeks. So I was hospitalized for those 2 weeks. So I got my missus to bring me in an exercise mat, and I just started rolling and crawling, doing the sequence and trying to restore my patterns. My missus came in and sneaked me out in a wheelchair so I could watch the Liverpool-Newcastle game halfway through. But other than that, it was just me in my private room doing the neurodevelopment sequence. But then with the odd visit from a physio who would then, try to get me to do the classic rehab stuff, which, that was when I was just got it in my head. I'm not having this. I'm not staying here for this. And then as one which sort of highlights the situation. I got myself to something that could be described, or thought of as walking in those 2 weeks. But then the day before surgery, I had an assessment by a doctor and a physio, both of whom were probably significantly younger than me now. Like, it's unfortunate I could say that. And they did all of their numerous assessments, and it didn't actually include a deep squat. So as it happens, all my symmetrical hip patterns, that they weren't as badly affected. Asymmetrical hip patterns, I was just all over the show. So I still had, well, certainly by the end of those 2 weeks, I still had me squat. But out of those 3 people in the room, only one person could squat. The physio and the doctor didn't have a deep squat. Now, both of them would consider themselves to be physically fit, which sort of what can that mean? And to them, to be physically fit as such, but yet they can't do a deep squat. And yet they're also going to teach and rehabilitate patients to walk. So that's that summed it all up for me. And so I had the surgery, and I was absolutely smashed by that. I mean, brain surgery is just controlled trauma, and the usual operation is between 2 and 5 hours is considered a long time, and it's a reasonable rule of thumb rather to equate the extent of the impact of the surgery with the duration. I'm sure if you just rummaged around with a blunt spoon for about 2 hours, like, it wouldn't be a good outcome. But normally 2 hours compared to 10 hours is a significant difference. And afterwards, I was smashed to bits. I couldn't even crawl. Obviously couldn't walk after the stroke, couldn't crawl after the surgery. When this was the weirdest thing, when I managed to get myself into a quadruped position, I couldn't crawl. It just wasn't in the program to be able to work out how to move a limb, but I could actually feel gravity. My reflexive stability was that destroyed. If you ever get on a spinning wheel in a kid's playground, and I'm sure you've been in a lot of kids' playgrounds, Eric. And you get on a spinning wheel.
I don't know what that's supposed to mean, Steve.
And you get centrifugal force, sort of throws you out. I could feel gravity in that same sense sucking me into the floor. And well, just once again, I started the neurodevelopment sequence, and then I had the conversation with the physios when it about 3 days after. It spent 3 days in intensive care. Once we come out of that, I spoke to one of them about my my rehab plan, and I said to him, I said, look, can you tell me that walking is not dependent on competence in spinal dissociation or rolling and crawling, or the coordination of that? He said no. I said, all a hospital bed is going to do is just keep me safe. It's going to make it difficult to get out. I'm going to be losing my mobility. And if you can't teach a skill in a range of movement that doesn't exist. So unless you can tell me I'm wrong on any of them, I'm out of here today. And he said, well, I can't. I said, okay, ta-da. I mean, I was respectful with it, like, but that was me. I was gone. And then, went home, and I resolved I wasn't going to even try to walk until I had competence in all of the fundamental patterns. And so I just, instead of having a 1 hour spell with a physio every couple of days, I was living my rehab, learning the skills in exactly the same way as as we all learnt our fundamental patterns. I would crawl everywhere. Obviously got the rolling first. And then if I needed to get anything, if I wanted something from the kitchen and I was watching telly, then I would crawl through to the kitchen, get whatever it is, and crawl back. When I went to go to bed at night time, I'd crawl from the living room up the stairs and into my bedroom. And then I think it was 14 days. I'm not sure if it was 14 days after I got home or 14 days post surgery. I was back walking again. In something that could be, self-ambulating without fear of going like a ball through skittles, like, and that was it basically. The story on that.
So, we're gonna ask Crispin, a question here. So, Crispin, as a physiotherapist, how did you feel when you first heard of Steve and his story, and how he really didn't follow the traditional treatment and was able to accomplish what he did? How did you react to that?
I mean, I met Steve purely by chance. I actually work in the hospital where he was operated on, but we just met, socially outside. I just happened to be in the same space where he was giving a talk to some other people. But because movement has played such a powerful part of my life, I was so drawn to his narrative and his story. And I thought to myself, I think I was pretty excited, to be honest. I mean, as rehab therapists, I think we can all relate to a good success story. I think all of us, I mean, for sure we can learn from our failures as well. But I think as a rehab therapist, I think we're drawn to people's successes. We want to find out more about why, what was it, what were the components of that successful rehab. And I remember thinking, I think, this could help a lot of people, actually. This is, and I was thinking that there are like two aspects in particular which really kind of drew me to what Steve was doing. First of all, it was his mindset, because I think whatever field of rehab we're working in, elite athletics or what I do like in pain management, I think confidence is a massive thing. And Steve seemed to have this in bucket loads, like to have the confidence to check yourself out of hospital and engineer your own rehab plan. That like takes internal locus of control to like another level. So I was very interested in his mindset, and what is it about Steve that might help me help other people to gain more self-efficacy. But the other thing really which stood out was, well, what system is he using? What process? And is this process repeatable with other groups of people too? So then he told me about the neurodevelopment sequence, about FMS. Later on, I was able to do a couple of FMS courses, which was just, that was a fantastic education in itself. But I just started looking at my own clinical practice to see, okay, based on this these systems that, Steve is using, based on, good physics, good biomechanics, good neuroplasticity, solid bedrock of science. What do I as a therapist now need to jettison because there's some other more useful information to hand here? What kind of stuff have I been using which may no longer be so relevant? and to start using some of these things in practice myself. So I kind of liken the whole thing, like if I was kind of trawling the North Sea for oil, I felt like I hit on this kind of amazing kind of oil field, which is gonna kind of bear fruit for many years to come, hopefully.
So talk to us a little bit about, in Crispin, you especially as a physio, if this were to happen to someone, as it does, unfortunately, every day, in another part of the world who doesn't have access to Steve or someone who knows what Steve knows, what's the general standard plan of care and expectations for someone who had a situation similar to Steve's with that type of brain injury?
Yeah. Well, that's a good question, really. I mean, it's kind of partly the old thing, isn't it? Like if someone has a problem and they met 20 different therapists, they might get 20 different rehab plans. but in general, I would say, based on my experience of in a variety of kind of clinical settings over the years, I guess success generally in the traditional sense is measured by how quickly can we get somebody from lying to sitting into standing and then walking. And that metric of success is really based on, how quickly can we get someone to that, endpoint of being able to stand and being able to walk. And, like I was in a conversation the other day with an amazing doctor, really lovely colleague, a guy, a consultant who heads up the brain injury unit in Bristol. Really good doctor. And I was telling him a little bit about the MDS and a little bit about what Steve had done. And you could see that it was, I kind of got the sense that was a pretty unusual concept to have talked about. And I remember he spoke a lot more about the just the joy that patients get when you get them up into standing for the first time, try and get them to walk with the aid of a walker or parallel bars or something. And I think that's generally the aim of rehab at the moment. So even at the cost of some pretty maybe unhelpful compensations in the long term and using various kind of walking aids or devices, I'd say that's the mainstream. And it just misses out so much. When I learned about what Steve did to rehab all of those components, all of those really important components that leading up to walking, that subserve walking, it just makes so much sense,
So, Steve, I know you have some insight into this in terms of expectations and lack thereof, unfortunately, in some cases. And I'm going to have you tell your story and a little bit about your experience getting to present, your story at some pretty big places. But let me backtrack. I promised I'd tell the story of Steve. I had met Steve, as he mentioned, at a bigger summit that was quite a while back, and didn't quite make the connection that a couple years later, I was teaching an FMS course here in New Jersey, and Gray Cook was coming in and teach the last day with me. He gets there and he, on the day before, and he says, "Oh, have you met Steve yet?" And I said, "I might have. Which one is Steve?" And he says, "Well, he's sitting in the front row over there." I said, "Oh yeah, there's a couple guys sitting up in the front. They were at one of our summits. They're real nice guys." He's like, "Did he tell you his story?" I said, "No." And he proceeds to tell me his story, and I'm like, blown away. And I grabbed Steve and I said, "Listen, what you've done is remarkable." I said, "Would you be cool with like sharing your story after we get back from lunch?" And so Steve, has his entire journey from post-surgery on that he chronicled on video, and he has it posted on Facebook. We're going to put the link up because if you need to turn your day around, I need you to invest 10 minutes and watch this video. So I tell everybody in the class, I said, "Listen, you need to be in your seats when we get back from lunch. I'm telling you, it's going to be worth it. It's going to be better than anything I'm going to teach you in the last 3 days." So we get back from lunch and everybody sits down and I just put on the video. And when I tell you, there was not a dry eye in the entire place, and people are blown away. And I'm like, "You think that story's cool? Well, that guy's sitting right here." And he came up and he told the story, and it was remarkable. You could hear a pin drop, and it still gives me chills to this day. So from that point on, I said, I got to keep in touch with this guy. Fortunately, we've been able to become friends and stay in touch over the while. And then he reached out to me, a couple of weeks ago and said, "Hey, we're doing this thing. It's called the Movement Project. Would you be, interested in getting involved? And I said, if I can lend any, granular piece of help into this thing, please let me do it. And I want to have you tell it, Steve, of what you're actually doing with this movement project, because it's nothing short of miraculous. Tell us kind of how it came to fruition and who's part of the group and what are some of the things we've been able to accomplish with that.
I suppose it actually has its genesis back in around about the time of the conference in New Jersey that you just mentioned there. Because pretty much after the results I had with my own recovery, and then knowing what the classic approaches were, how people are being let down by it, and obviously not let down by individual therapists or whatever. They're doing what they're taught, but there's so much more that's possible. And if you get people who are motivated to own their own recovery, then the most brilliant people to work with, and the most rewarding, if you actually see the results. So I'd been involved in a number of brain injury forums, trying to put out help where it could, etc. And then that's when I first came across Chelsea, who you've obviously met, Eric. And Chelsea's still got her challenges now, but way back then, oh mate, she was pretty damn smashed up. She couldn't form an opposable thumb with any of her fingers, couldn't touch her nose. Her ataxia, she almost presented like a Parkinson's victim. It was that bad. But she had this brilliant attitude on her, and she would post videos of the rehab she was doing and the work she was doing, and they had her doing isolated strength exercises, and I say her attitude was magic. So I thought I've got to try and help this girl. So I reached out to her over the internet, and then like most unsolicited contacts from a near 50-year-old bloke to a very attractive late 20s girl, I was routinely ignored as some sort of internet stalker, But then when I came over for the seminar in New Jersey, with those brain injury forums, I said I would do my own seminar. And Patrick Prisborowski, a friend of yours, Eric, he loaned his studio for me to do the seminar. And Chelsea actually only lived 15 minutes down the road. So that's how Chelsea then came. I took over her rehab, and obviously did all of this over the internet. This is one of the things which, what I'm able to achieve over the internet as opposed to in person, if these methods were being employed in person by people, then the results you would get would be incredible. And so the results I got with Chelsea, they became apparent within these forums. Some other people got in touch with me for me to do their rehab. And then I was sort of thinking of ways in which I can try and do the most for the most. But then I presented at the World Congress for Neuro Rehabilitation in 2020 and was routinely ignored. So I thought, I want to go back and have some solid results, and maybe that will, get noticed a bit more. So my intent was to recruit a suite of participants from the brain injury forums, and then take them through a neurodevelopment sequence and movement pattern led rehab for 3 months, and then document the results, which we did do, and it formed an abstract which I then got accepted for the next World Congress. But the results we were having with them, and I obviously recruited Crispin right at the start of the project, and then the results we were having with them was just so incredible. We didn't have the heart to stop it, so we've kept it going since, and the I've always loved working with motivated people. That was, one of the best aspects of my time in the forces. And then when I've trained people since, or certainly when I've been doing the rehab, working with motivated people is a reward in itself. And on these sessions, as you've now seen yourself, we have almost like a miracle a session, and it's just brilliant. And what we're able to achieve, one of the, I suppose it was in one of the questions you asked earlier of what the standard treatments and plans are. At the World Congress, there's a clinical pathways sequence of lectures, which is supposedly the gold standard in neurorehabilitation, and one of them is in relearning to walk. And in one of the in this lecture, they put up a graph showing the recovery curve, which starts flat, goes like a hockey stick in the first 3 months, starts to tail off 3 months to 6 months, and then just flattens thereafter. The expectation is no significant progress after 6 months, and then zero progress after 2 years, or 2 to 3 years, which was my original estimate. And then everyone on the movement project was already in that chronic phase. And then the results we've had, all of which is documented, or we've got it all on video. So there's no, there's no trying to deny any of it. It's just a brilliant thing to be part of.
Hey, everybody, a quick break in the action here. Hope you're enjoying the show, and we appreciate you listening. We're working hard to bring you the highest quality content and best guests every single week. So if you could do us a big favor and go and like and subscribe to the show on whatever platform you get your podcasts on, it would be greatly appreciated. Be sure to listen at the end of the show also to find out where you can find out more information about our courses, as well as a special discount code for all our listeners. Thanks again, and let's get back to the show.
So can you guys clarify, and as simply as possible, because when it comes to, brain injuries and the brain in general, it's some pretty in-depth stuff. So could you guys, sort of give us some insight on some of the classifications of brain injuries that you work with within the group? And are there any differences as far as the prognosis and expectations within those different types of classifications of the injuries?
Well, they often get classified by the region of the brain which is impacted, and there are different functions which are associated with different areas. But to be honest, that's just more going to give you some background on likely expectations of symptoms. You're going to have either acquired brain injury, which is one which you could say develops internally, or you'll have traumatic brain injury. Worked with both, and it's ultimately there will be a mechanism of injury that compromises an area of the brain. When that area gets compromised, the function which it is participates in will in turn be compromised, and you can look at it as generic as that. So there's two different types of stroke. One is ischemic, which is where one of the vessels gets blocked, that's the most commonly encountered, or certainly aware of, type of stroke. And then you can have a stroke which is caused by a bleed, that's what mine was, a brain hemorrhage. It is a hemorrhagic stroke. But within the movement project, we've had guys who've had tumors, so a tumor removed, a meningioma, different areas of the brain, although mostly as it happens by chance rather than design, they're mostly brainstem injury patients, which often is the most far-reaching damage. But anyone who suffers movement compromise as a result of brain injury would be eligible for it. I think there's a very limiting belief out there that, certain areas of the brain specialize, or all areas of the brain specialize, and then if you damage that, right, that's it. You've lost that skill and you have to work around it. Well, the brain's ability to rebuild different patterns, neuroplasticity, that's there for life, and that was one of the things which I thought was just bad science about the classic approach, and this expectation that once you're 6 months past injury, you're not going to improve. But if neuroplasticity continues for life, then why so? But I think what you've got is classically, well, you could say broadly brain injury patients. Obviously, a traumatic brain injury could happen to anyone, but acquired brain injury is people are going to be probably 50 plus. I mean, let's just say 40 plus. But if you look in the Western world, what 40 plus person has got anything like authentic mobility? And if they haven't got authentic mobility, then first of all, is there sufficient range of movement to actually attempt the skill? And if there is, you're going to be decreasing the biomechanical advantage and increasing the challenge. So you've got increased physical challenge, but decreased neurological capability. Well, that's not going to be good. And if their movement lifestyle before the stroke is insufficient to maintain good mobility, then after the stroke, it's going to be going downhill fast. And so you've got 6 months of exceptionally compromised movement lifestyle. Well, what's that going to do to someone's mobility? And, is there a correlation there that, you've got what's termed spontaneous recovery, which is, the body's ability just to recover by itself. And my sort of thesis on it, is that, that 6 months is largely what spontaneous healing's going to give you, and what the rehab's doing. It might help you with activities of daily life and be able to sustain, your own life to an extent. But as far as regaining authentic movement, it's not going to happen. And then over that 6 months, your mobility's gone downhill, and so your chances of restoring that are going to be zero. I mean, the day before these people would have their stroke or brain injury, yes, they could walk then, but that's been built off, first of all, a platform probably around about age 12 or 13, where they had authentic mobility and where they could walk then authentically. But then every day since then, when they start sitting down more than as the greater part of the day, they're having a day-by-day loss of their mobility. And so you'll have a day-by-day compensation within your movement patterns. And that will happen all the way up to the day before their brain injury. Well, yeah, they could walk the day before, but they didn't have the necessary mobility to be able to learn to walk, should they have to. And then bang, brain injury, mobility only gets worse. And to use some parlance, which I first introduced me by Gray, which, is it a hardware problem or a software problem? Now, ironically, in the sort of athletic populations, everything is solely considered a hardware problem. Very few people ever think about movement patterns, software. But in the brain injury world, everyone just thinks of it solely as a software problem. Never mind the fact that they haven't got the range of movement for the skill they're trying to give them. And, they talk about balance as if balance is just a neurological thing. But the structural component of balance is enormous. I sort of have very much been aware of that myself, because, I'm still working on my own recovery now, and certainly constantly working on the musculoskeletal part of things to either maintain good mechanics where I've got them and regain them where I haven't. And I'm 6 years on, and in the last 3 months, the difference I've been able to achieve in my single leg balance has been night and day. And that's all been because of soft tissue intervention, all hardware problems. and it just flatly doesn't even get acknowledged in you know in the relearning to walk world, you know. So I'm not sure if that answers the question. I've forgotten what it was now. Just rambled on.
Well, I can attest in being a fly in the wall for some of these movement project sessions that there literally is a miracle happening every single time I'm able to have, you know, the good grace of being on one of these things. And, you know, I had this discussion with both Crispin and Steve, you know, before the last one, and talking about some of the things that I wanted to try to introduce, not because of any great brilliance of my own. And I will, with full transparency, say I'm incredibly out of my league in dealing with what these people are dealing with. But the reality is that I'm, you know, just a simple strength coach and trainer, and I have a lot of experience just looking at movement. And it's from the perspective of, okay, well, if you can't do this, here's some things to help you do that. And if you can't do that, or some of these things, then here's how you regress them down. And if you can do that, well, here's how we're going to progress you forward. And it's pretty simple, cut and dry, you know, principles of exercise progression. And that's all I've really lended in terms of this project. And when it comes down to it, it's really just movement, right? And so when we look at that, you know, for either of you guys, why really do we need to train? You know, obviously there's certain medical considerations, but beyond those, why do we need to treat these brain injury patients any different than somebody else who can't move well?
I think that's I think that's a really good point. I think that was enormously humble of you, Eric. Actually, I think what you've shared in the group in the last couple of weeks has been amazing. But I think this is the beauty of the system, really, where, you know, irrespective of whether someone is an elite athlete or a brain injury patient or anyone in between, you know, the well used checklist of the movement system and the neurodevelopment sequence is it's just so useful, and to kind of go through that checklist and say, well, you know, can you accomplish this pattern and this pattern? Whereabouts does your successful challenge become an unsuccessful challenge? And why is that? Is that a mobility problem or a software problem? I think it's just I think it's a great example that, for me, this group is a great example of how you can apply this single system to almost any kind of health condition which causes movement deficit. But when Steve asked me to go on this project, I said, no way! What am I on earth going to offer this group of amazing people? And I have to say that I've learned more than I've offered, but I can still see the clarity. Like, that it makes sense to just go through the system, you know, go through your checklist and see what's missing, really.
Yeah, I think that's an overplayed humility on both your and Eric's part there, mate. You know, most definitely. But the thing is, if something would be either a blocker, a challenge, or a deficit for what we, for purposes of this conversation, we'll call a normal, healthy person, well, it's going to be an order of magnitude higher for the brain injury patients. So you wouldn't and can't ignore that. And you know why they would, and then just try to go to a more complex skill. You know, like I've had, you know, whenever the people who I try to, in the medical fraternity, who've had the conversations with, they tend to fall into two groups. You know, existing neuro rehab professionals and non-neuro rehab professionals. And the non-neuro rehab professionals I talk to, they, you know, engage with it exactly as Crispin has and think, that's so logical. Why wouldn't that work? It's obvious now you say it, and get quite enthused with it. When I talk to neuro rehab, I mean, maybe it's my delivery, I don't know, but they just take it as a dominance dispute, and the trying to defend the position of going straight to walking, when because that's, I don't think we've covered that here. That is like the standard procedure is you go straight to walking. And if you can't walk unassisted, then it's assisted walking, and it's high intensity, by the way. High intensity attempts at walking, because high intensity exercise releases brain derived neurofactor, which assists or promotes in the building of neurological patterns. Well, yeah, great, but if you're not building the right patterns, it's of limited use, you know. And how can you advocate going straight for something where the people don't have the mobility for it and don't have the dependent skills? I don't understand how someone can have that debate. And then also that they're working to an accepted target or constraint that they're only going to get significant improvement in 6 months. And we routinely, it's absolute routine, that in the movement project, every single person on there has got, what would be considered significant improvement by anyone's standard, but by brain injury standards, beyond significant. And one of the few cases, well, I'm usually not lost for words, but I'm lost for more cultured words.
So I have a question for you guys. So, when you look at the NDS, and it's basically some simple to complex movements, and we start in that supine position, and then we start to roll and we go into prone, and we have that whole entire sort of systematic approach in which kids do naturally, because kids don't have movement coaches, right? Like, we really don't. So the question I have is, like, let's say, with a toddler, when a toddler is learning to stand up, they usually stand up from the bottom of a squat, and then they stand up from the bottoms up. So, and one of the ways that they learn is via feedback. By, you'll see a toddler and they'll move around and they'll try to find their balance, and they'll try to find a way to distribute their weight. So the question I have with kids, they're just going to fall over and, fall on their butt. They're not too far from the ground, so it's not a big deal. The learning comes from the experience and trial and error a lot of the times when it comes to, kids and toddlers moving. How does that look when you're working with someone that's had a stroke? Because, they could be, they're generally older, and there could be a safety component where a toddler would get feedback from falling on their butt and then standing right back up. How do you create an environment, or do you create an environment for people that have had strokes or, brain injuries, where they can get the feedback of failing, but they're still safe?
Great question. But it's built right into the system, and it's built into that same system. That applies to the baby, because although but it can stand and fall on its butt, and that's maybe a little bit different than for the adult. Where it learns the skills to be able to stand is when it's going from crawling to kneeling. And just for the baby and for the adult, that's when it will crawl over to something that it wants, and then come up onto its knees to free up its hands. So that's it always has the reason to move. That's what needs to drive behavior, as opposed to cognitive commands to muscles to do something, which, especially if you're in a sets and reps environment, it doesn't make sense to the movement brain, and when you've got either necessity or might be curiosity or a reason to move, you would crawl to it, you come up to free up the hands, and in doing so, well, you've got a vertical pelvis, you've got a 2-point base of support in your knees. So everything from the knees up is standing, but you've got a reduced challenge. You've got a reduced center of gravity. You've got 2 huge feet, which are in fact your tibia, but the cost of failure is just putting your hands down. And that's the same for the adult, and that's the same for the baby, because what you were talking about there, when the baby tries to come up from the squat, or even when it and they can do it both ways round. I know my grandson learned to squat from standing, as opposed to learning to standing from squat. Mm-hmm. If they didn't know how to fall at that stage, then there would still be a cost of failure with the baby. If they were falling, just like a post to left and right, which I mean, that happened to me one time in the hospital when I was having one of my assessments. I just fell like a tree trunk. It was a bizarre thing because I sort of clocked the moment, well, which most people do when you think, this is unrecoverable. But I also just didn't have anything in the program to either put a hand out or something. It just wasn't there. I was just seeing. Fortunately, I fell onto the bed, which was chance rather than design, and you just was just grateful for that. So it's built into the system in that respect. But the sequence in which you learn the skills is a similar thing again, because rolling, most people probably aren't aware of the significance of rolling, but it's dissociation of the spine. Obviously, when you walk, left foot forward, right arm forward, well, that's your shoulders are pointing off in one direction, hips on the other. If they're on the same spine, so that spine's got a corkscrew. Now, if the spine corkscrew, every one of those, well, if you just go lumbar and thoracic, you've got 17 joints there. How was that for quick maths, Eric? Yeah.
Better than me.
If that dissociates, you've every one of them is going to be in a unique position, but every one of them has got to maintain congruity with the joint above and the joint below. Now, neurologically, that's a huge deal. So learn it on the floor where you can't fall off. But instead, you'll see it when you've got a brain injury patient who's lost the rolling pattern or the dissociation pattern. You get that Robbie the Robot stroke walk where the hips are going with the shoulders. And part of that as well is when you identify cost of failure. If there's risk of failure, then you'll go into protective bracing. If you go into protective bracing in the core, then that spine ain't dissociating. And
I think that's something that I have seen in rehab, not just in neuro rehab over the years, but in care homes and so on. I was redeployed to some care homes during the pandemic, and by missing out those really important stages in the NDS, and someone tries to go from sitting into a standing position, and it's exactly like you say, Steve. Everything braces up. And now all they're doing is they're just surviving that walk. However far the therapist is trying to get them to walk, they're just surviving it. The breathing pattern goes out the window, and it's and whatever neural learning is taking place, it's probably not that helpful.
And I can speak from experience. If you're stood up and you haven't got the movement skills, then you have that fear, and it's all consuming. You're getting given instructions, tense your glute or something like that from the physio, and you're hearing nothing. Your focus is on survival.
So Steve, you were recently able to present at the World Congress for Neuro Rehab in Vienna, Austria. How is your message received by that medical community?
Yeah, I've sort of touched on it before. Everyone who wasn't a neuro professional, well, I suppose actually everyone who's there should be. Everyone who wasn't involved in movement rehab was fascinated by it and really enthused, and especially when I showed them the results. But everyone who was involved in the movement stuff, it was just seen as a dominance dispute. The only thing which is now considered to be the groundbreaking, or where they're looking to break new ground, mate, would you believe this, is exoskeletons. If people can't walk, they're trying to teach them to walk by putting them in something out of a science fiction movie, doing them at the RoboCop with them. And there's also direct brain stimulation, where previously they would drill. I mean, it's fascinating stuff. You're seeing some, God knows, capable and clever people drilling into the brain with electrodes into the brain and being able to elicit movement out of that. And actually, if they undergo it for long enough, they do reclaim some of the movement that they're getting there. And they can do it with almost like a skull cap now, which takes about 5 minutes to put on instead of having your brain drilled into. But the examples they were given was this guy being able to, I'm going into the divided by a common language now. I was going to say grab a crisp out of a packet. Now, would you call that a potato chip? Yeah, you would, wouldn't you? Yeah, that was it. He's got this skull cap on, and he can now take a potato chip out of a bag and eat that. And he was saying that's all he wanted to do after his stroke. But that, I think there's some expectations that are wrapped up in there, which imagine the investment that's gone into wearing this skull cap so we can take a potato chip out. Well, yeah, fair enough, great and all of that, but we do all of this without any of the cost. And one of the things is neuroplasticity, the ability of the brain to build new patterns. It's stimulated by experiencing new and expansive movement. It's not so much the other way around, and if you think about it, why that would be, like with when the brain's growing at its most rapid rate is when the baby's everything it's experiencing is new and expansive. And so you don't lose movement because you get old. I mean, this ain't my phrase. Like, you get old because you stop moving.
So I preface every time I talk about anything with neurodevelopmental sequencing and really just talking about the software itself of how our brain and musculoskeletal system kind of connect. And I say, look, regardless of who or what you believe in and how this whole thing was created and who wrote this software, the one thing I do know is that it's way smarter than me or anybody else in this room. And so the ability to tap into that is really where I think that the magic and elegance is. And so, as we're kind of coming to a close here, there was so many reasons I was excited about having, Steve, you and Crispin on, and not the least of which is that if at some point, somewhere, somehow, someone who's listening or watching this either goes, God forbid, goes through this themselves or has a family member or friend or someone close to them that goes through this, that what you have done from a very fact-driven, system-driven way, as well as a very emotionally inspirational way, is you have taken that traumatic incident and instead of making that kind of the end, a closing note, you've taken that as a new beginning. And to that, myself and anybody else who's involved in this, who comes in contact with your work, can't thank you enough for that. And so I think that's really one of the biggest things I wanted to get out there from this episode was what you've been able to do and kind of turning that whole thing on its head from an outlook standpoint.
It's not nice to hear. One of the things is I ain't got special genes. I mean, I suppose on the introduction, with ultramarathons and special forces, people might sort of think that, I've never been the most physically talented in any peer group I've been in. Well, except maybe when I was on the neuro ward. But I haven't been. Admittedly, I've got a decent amount of discipline and determination, which is that's what my ultra marathon was based on, and then also me time in SF. But as far as magic genes go, absolutely not. Anyone can do this, and everyone's already has done this. That's when they taught themselves to walk the first time. I mean, we're going to look with the movement project, and something I would dearly hope you can be part of, mate. Is I'm gonna want to try and use as a vehicle for the next abstract I'm going to submit for the next World Congress. I want to go down the movement project route again, but I want to try to use the SFMA. I want to try to establish objective metrics for mobility for each one of the neurodevelopment sequence patterns, and to try to present that, because for me it just makes it utterly compelling. You say, right, can the person exhibit these movements? Now, if they can't, are you honestly going to try to advance them to a more complex skill that is dependent on these patterns, are you going to advance them if you haven't got these, these movement criteria? And then if you haven't, get them, and then use the neurodevelopment sequence patterns to build from there. And I've already shown with me how successful it can be, and then with all the people we've done in the movement project. But I think we can get demonstrable and objective results with this, because if everyone's in the chronic phase of recovery, that's just going to act as their own control group, because the industry and all of the stats say you can't have significant improvement. If we get a suite of brain injury patients, run them through the applicable aspects of the SFMA to see whether they haven't got there. If they haven't got them, we take them there, take them through the neurodevelopment sequence, and then I think we can present it in a way that it can't be ignored. I mean, I've had a preliminary chat with Gray about it, and Gray's interested in it as well. And obviously, if he is, and if you are, Eric, then it will properly fly.
I would be honored. Now, Perry, told you we had a doozy at the onset of this one. This one's going to be tough to top. There's one thing that we teach people about. We had, next week we're talking about people, or I think the week before we're talking about people getting jacked or making people faster. Like, this is a whole nother level of things.
Yeah, no, this is performance stuff is fun, right? It is like, you can change someone's life by getting them a better 40 and getting their better for the combine. But this is truly life-changing stuff that you guys are doing. And, I think this is the future of rehabilitation when it comes to strokes and brain injuries. It's still in the infancy, right? And you guys are sort of leading the way, but, I'm excited to watch your journey and learn from you guys, because I have a little bit of knowledge on this stuff, but, yeah, I think you guys are doing an incredible job, and I look forward to seeing the lives that you guys change through your work. So I just want to say thank you for sharing your story and doing what you guys do, because it's an honor to learn from you guys.
Well, I'd like to say just thank you for I see you guys as the leaders of this whole system that enabled Steve to do what he did. Like, even from when Steve was back in the forces, if it wasn't for you guys like paving the way with this kind of approach, none of this would have been possible. And I just feel really privileged to even kind of witness what you guys have all done anyway. So yeah, so thank you so much.
Yeah. And I know it's time for me to shut up. The penny's just dropped on something. I don't know why I didn't make the connection earlier. This is particularly relevant to Mike. But Eric, do you know, I've told you that Chelsea has now started doing jiu-jitsu.
Yes, that's awesome.
That's spectacular. That's unbelievable.
And the way it's bringing her on, because of it's a real reason to move, extreme tactile feedback, and talk about being able to get out of your own way, and it's non-cognitive movement control. It's been brilliant for her. We've got videos of it as well, which I'm sure Mike might be interested in. But
I would love to see that, because that's phenomenal. Yeah. I would love to see that.
And I've been looking for a jiu-jitsu instructor close by to me, but as of yet, no joy, because for instructing movement, and for one of the most primal reasons to move, which would register with with your neurology, you couldn't get anything better. All ground-based skills as well, But anyway, I'll wind me neck in now. But maybe we'll have another chat on that one, Mike, and I'll send you over some of the videos of Chelsea's work.
Yeah, and we'll chat as well, because I have some connections that would be able to help you as well. So we can definitely chat after the podcast at some point, for sure.
And we are no doubt going to share some clips, along the way, of some of the things that these guys are doing, because it is remarkable. And I highly encourage you to click on Steve's Facebook story, which we're going to share the link to as well, and reach out to them if you yourself or know someone who's in this situation that they may be able to help, because this is groundbreaking and miraculous, to say the least. And so I can't top anything else that's been said here. So I'm going to just thank these guys again for their time and their effort and their mission and everything they've done to inspire me and so many others. And want to thank you all for listening. And this has been the Principles of Performance podcast. Thank you for listening to the Principles of Performance podcast. If you've enjoyed our content, please like and share on your social media outlets, as well as subscribe and give us a review on YouTube, Apple Podcasts, or whatever your preferred platform is to listen to. For more information on the Principles of Program Design courses and workshops, visit us at www.principlesofprogramdesign.com and follow us on all of the social media channels where we post new content every day. To save 10% on any PPD courses, enter the discount code PRINCIPLESPODCAST10 at checkout. If you have any questions we can answer or suggestions for the show, you can email us at info@principlesofprogramdesign.com or message us on social media. Thank you again for your support.